Good to go.
Yeah, she said if if the tablet doesn't work, she's gonna text me. So that's why I'm like,
So she's sending you your questions.
yeah, there she go.
What's on the tablet?
The questions.
They're good and organized, at least. I think they are.
Oh yeah, always. Oh yeah, 6 o'clock. Let's go.
So you were on the board.
I was
Yes,
for
I
many
didn't know
years.
that.
I led it 1 year.
You what? You
I
led?
led. Yeah, I was the chair. Um, many moons ago.
Yes, Teresa sends her best. She's like,
But you know what? I'm gonna reconnect with you all because of the work that I'm doing.
Please join us.
Yeah, I want
6
to
p.m.
provide
in the Old Fine Arts
to
Room on the third floor as author K.T. Braxton discusses her new release, The Dawn in Heels, a story of faith, growth, and discovery. That's right now in the Old Fine Arts Room on the third floor. Author K.T. Braxton.
Hello, everyone. We'll be starting in about 2 minutes.
who's that?
my daughter. She scrubbed in to surgery, so she's a junior. Well, soon, I'm sorry, she's a rising senior at Xavier University of Louisiana. She's studying biology, pre-med, and she had fellowship in Wisconsin, the Medical College of Wisconsin.
Yes, yes.
And so that's where she's at. She scrubbed in. I know, so I'm so proud of her.
So is she going on her way to medical school?
When she graduates.
She's going to apply. Yeah.
Yeah, she's gonna apply. She's looking at MD, PhD programs.
Oh, love her.
Yeah, so.
That's a girl after my own heart. That's wonderful. This is a. Oh, aren't you proud of her?
Yeah, so
No,
she
you
sent me
must
the
be.
OR pick.
Lordy.
A little screensaver. Now you're their chief development officer at Corktown Health.
Oh, now I'm introducing myself as chief advancement officer. Just fundraising and work with external
Yeah,
relationships.
you're doing more than that.
It's more. I'm kind of a professional fundraiser. Trust me.
It's a okay. Okay.
I really. My background is in public health. Yeah, I was AIDS director here in the city for a long time.
Okay, we should be all set to start.
Went to Teresa and my young was starting LGBT center in this town. And here's how.
Okay, good evening, everyone. On behalf of our team, the Office of Community Outreach and Engagement at Karmanos Cancer Institute, I'd like to welcome everyone to tonight's Community Conversation on Cancer series. Thank you to both those who are joining us online and in person. My name is Ali Faki, and I'm happy to be opening us up tonight. The purpose of this series is to connect our community with our science and our science with our community. These conversations are a space to share knowledge, listen deeply, and build stronger connections between our researchers, providers, and the people they serve. We are proud to be partnering with the Detroit Public Library on this entire series, and we thank them for their collaboration and support. We also want to recognize our community partners, some of who are in the back, and I'll read off the list. The Pink Fund, We Run 313, Healthier Black Elders Center, National Council of Negro Women, Corktown Health, Cancer Thrives Network, Western Wayne Family Health Center, Michigan Ovarian Cancer Alliance, and New Day Foundation. Thank you. We're grateful. Oh, yeah, you guys can clap for our community partners. Yep. We're also grateful for Global LT Services for translating in both Arabic and Spanish. If you're joining us online, you can select your preferred language by clicking on the interpretation icon at the bottom of your Zoom. And if you're joining us in person and you would like translation services, we have iPads and headphones in the back. A few quick housekeeping before we get started. For our online audience, if you have any questions during this event, please use the Q&A feature. on Zoom. For those attending in person, we kindly ask that you hold your questions until the end. Please note this event is being recorded so we can share it out afterwards for those who aren't able to be here. And for those who are in person, restrooms are straight out this door and to the right. Finally, I'd like to acknowledge our speaker, Dr. Ammar Sukari, for joining us tonight, and our three moderators, Jim Scott, Katrina Studvent, and Patrick Yankee, who will now introduce themselves. Thank you. Jim Scott.
I knew that.
In case you forgot.
Good evening, everyone. And very briefly, I'd like to say that, again, my name is Jim Scott. It's an honor to be here. As a cancer survivor of 2 forms of cancer, I devote much of my time to several local, national, and international cancer research and advocacy organizations. The World Bladder Cancer Patient Coalition. I'm on a panel of the Patient Advisory and Bladder Cancer Advocacy Network. Nationally, I'm on the Speakers Bureau and Survivor to Survivor program. Gilda's Club, members of the men's group, on the board of directors as well. And Cancer Support Group at Hope United Methodist Church, I am the chair. And also, I'm proud to be a member of the Black Men's Cancer Action Council. Congressionally directed medical research programs for the Department of Defense and their peer-reviewed cancer research program. I'm there as a consumer reviewer. And I'm so honored to be here with you this evening to learn more just like you. Thank you.
Greetings, everyone. I'm Katrina Studvent. I have been a nonprofit executive for nearly 20 years, but I wear a new hat now. I lead a nonprofit focused on individuals with chronic illnesses and diseases, and I am also a 19-year breast cancer survivor and cancer research advocate. Yeah. And that is my connection to tonight's talk.
Hello, everyone. Good evening. My name is Patrick Yankee, and I work as the Chief Advancement Officer at Corktown Health here in Detroit. Our organization began in 1986 at the beginning of the HIV epidemic in Detroit to service individuals in our community. And for the past 39 years, we've provided care to thousands of Detroiters living with HIV. In 2017, we began a new primary care adventure here in Detroit by opening Corktown Health. We changed our name from Health Emergency Lifeline Program to Corktown Health and opened Michigan's first community health clinic to focus on the LGBT community. Since then, we've served about 4,000 individuals a year. At Corktown, I'm usually the person raising the money and asking you for money, but tonight I'm also grateful to share with our community partners and the opportunity such as this one to have community conversations like this. So I really appreciate the invitation and thank you everybody for joining us. I'm going to, thank you. My mother used to say, just take a break, Patrick, and you let it in a little bit. Well, I'm going to turn now to the pre-question. We have a polling, a pre-knowledge questionnaire. How about that? You all received this, or it's on your chair as you came in. There are 2 pages. One's white, one's yellow. And before we dive into today's topic, let us start with a few quick questions. The same questions appear on both of those sheets, so you'll do one before and one after. To see what we already know, or what we think we know about this subject. Don't worry, this is not graded. It's just a way for us to reflect on the current understanding and get us to thinking. This will help us connect with what we are about to learn and what we already understand. For those of you joining us in person, you should have received the packet. There's a white one, we already discussed that. I think, see, by looking at you, already found them. Upon completion, please tear off the top sheet and hand it to one of the team members who will be coming around to collect them. For our participants joining us via Zoom, a poll will be launching on your screen in just a moment with the same 3 questions. Please take a minute to answer them using your device. I want to thank you all for your participation.
In addition to being excited to be here tonight with our community partners and you, the community, I have the honor of introducing tonight's keynote speaker. Dr. Amar Sakari is a professor in the Department of Oncology at the Wayne State University School of Medicine, Medical Oncology Division Chief, leader of the Head and Neck Multidisciplinary Team, and member of the Breast and Thoracic Oncology teams at the Karmanos Cancer Institute. Dr. Sakari received his medical degree from the University of Aleppo Medical School in Aleppo, Syria, completed his residency and fellowship at William Beaumont Hospital in Royal Oak, Michigan, and is board certified in medical oncology. He has a special interest in early development clinical trials, immuno-oncology research, head and neck cancer, and thoracic oncology. Dr. Sakari is an active clinical and scientific member of Karmanos with significant experience in clinical research. His research focus is in conducting clinical and translational research trials to improve treatment strategies for patients with head and neck and lung cancers. Dr. Sakari is also a member of the Eisenberg Center for Translational Therapeutics at Karmanos, which houses the Phase 1 clinical trials program, and he is currently the PI on multiple early development Phase 1 transitional clinical trials in head and neck cancer, thoracic oncology, and other solid tumors. Dr. Sakari has been a champion in improving the quality of cancer care, serving on the MSHO Board, MOQC Steering Committee, and National Cancer Institute Head and Neck Steering Committee. So without further ado, we'll hear from tonight's speaker.
Hi, everyone. Thank you for having me, and thank you for the invitation. It's a great pleasure, and I think this is part of our mission at Karmanos Cancer Institute to reach out to our community and try to increase awareness about cancer in general, and especially lung cancer. It's one of the most common cancers and actually the most deadly cancer. So it's great to increase awareness for the community, for people for their own health and for their families. So already I got great introduction, so I don't need to talk about myself anymore. That's what we want to do. We're trying to learn today about different type of lung cancer. What's the risk factors? What's the symptoms? How we usually diagnose lung cancer? And what's the research advancement related to lung cancer? Also, I would like to focus on early detection, prevention. You know, there is always, in prevention, there is primary prevention and secondary prevention. Primary prevention is to prevent the disease. Secondary prevention is to find it early, so you prevent getting diagnosed at advanced stages. So in primary prevention, for example, in lung cancer, number one is to get your public to adopt healthy habits, meaning no smoking, no drinking, exercising. That's the primary prevention. So in lung cancer, it would be mainly the campaign against smoking, vaping, hookah, all different forms of exposing your lungs to anything beside the air, because your lungs is just created to handle air, nothing else. The secondary prevention is, for example, in breast cancer, you do mammogram to find the breast cancer early at either the stage 0, the DCIS, so you could treat it, and it does not even get to the point that it's invasive breast cancer. In the lung cancer also, we have a similar technique that we could use to do that, which is a low-dose CT scan that we will talk about in details. So what is lung cancer? Like any cancer, other cancer, it's basically some of the normal cells in the body that transform to a malignant cells. That means those cells are growing without control and invading surrounding structure, surrounding tissue. It's kind of crowded your normal tissue, and that's how you get sick from them. So in the lung cancer case, those are the cells that basically the lining of your airway or inside the lung. lung cancer is the most common cancer worldwide. In the US, it's number 2, and but it's the most deadliest cancer. So the highest cancer-related death happened in the US, it's because of lung cancer. And if you count the death related to lung cancer, it surpassed death related to breast, colon, and prostate together. Together, yes. For example, if you have lung cancer, your chance to survive it for 5 years, it's only about 20%. Where if you have a breast cancer, your chance to survive it is more than 90%. That's how big the difference is. The lung cancer, usually we differentiate between 2 types. One is called small cell and one is called non-small cell. So it's basically, that's how those cells look under the microscope. But it's also related to the cell of origin, where the cells came from. So small cell, usually it's more aggressive type of cancer. Non-small cell, still not great, but it's not as aggressive. And the non-small cell has at least 4 different types. One called adenocarcinoma, which is mean gland, so that the cancer started from a gland in the lung, and that's the most common type of lung cancer. Then you have a squamous cell cancer, and then you have a large cell cancer. We did talk about that it's the leading cause of death in the United States, cancer-related. According to the American Cancer Society, in 25, we will have almost 226,000 new cases in the US, 124,000 or almost 125,000 deaths related to lung cancer in the 25. So that's why it's a very big public health problem in any country, especially when it's more smoking prevalence, it's becoming more an issue. In the US, it's actually better because our smoking rate is on the decline. Some other countries in the world, like China, for example, their smoking is on the rising. In Michigan, those are Michigan number, we will have about 8,500 new cases in Michigan. They will be diagnosed with lung cancer, and almost 5,000 deaths related to lung cancer in the state of Michigan. So we talked about primary prevention, and we said primary prevention from lung cancer is not to smoke. Also, there is some houses that could be built on area that has a lot of radon gas in the soil, and that could be checked for. But the secondary prevention, which is what we will focus on, it's the low-dose CT scan that you should have it once a year if you are from the high-risk group. And that meaning certain age, over age 50, certain smoking history, if you had smoked for more than 10 years back a day, or 20, let's say 20 years, but half back a day. That sometimes get people to be confused about it. There is a problem that we have a low screening rate in the US for lung cancer. Only 20% of eligible population to be tested or had that screening are getting it. And that's for different reasons. There is low awareness, low understanding of the risk of the lung cancer and the benefits of the early detection. There is the mistrust to the healthcare system, the stigma about that I did it to myself, I smoke, so feeling guilty and not trying hard to prevent those cancer from happening. Access and infrastructure, I mean, low-dose CT scan, you need to You need to have access to the CAT scan machine, access to the radiologist who has the expertise in reading those scans and differentiate between normal findings that if you get 100 people walking in the street and you got them in a CT scan machine, you will find 5 nodules. Only 5% of those patients have something serious that need further workup. So that's what access to expert in reading those scans, it's very crucial. Also, the eligibility to do this testing is a little complex and it's recently has changed. So even some of the healthcare providers, not very familiar with those guidelines. We did cover that, as I said, the challenging guidelines, the smoking history that sometimes get people confused. What's the risk factor for lung cancer? As we said, number 1 is smoking, and right now we believe, we thought initially that just cigarette smoking, but now we believe all type of smoking. Even marijuana smoking could increase the risk of lung cancer. As I said, exposure to some either environmental factors like the radon gas or occupational factors like asbestos or certain pollution. Family history of lung cancer, there's some genetic abnormalities that you inherit from your parents, and that would increase your risk of lung cancer. Also, chronic lung disease. So sometimes you get chronic lung disease because of smoking, but some people has chronic lung disease for different reasons, not just smoking, and that also increases the risk of lung cancer. What's the alarming symptoms for lung cancer? Persistent cough. Any cough that lasts more than 2 weeks, you should check it with your doctor, at least chest x-ray. Shortness of breath. So you used to walk a mile without a problem, and now you start having hard time breathing after you walk a few blocks. Especially stairs. When you climb stairs, that's a better test for your endurance than just walking. So when you climb stairs and you start having, you used to climb 2-3 stories with no problem, and now you're having issues, that's a red flag. Usually you could have chest pain, weight loss, that's a big one, and hemoptysis or coughing up blood. So those are the weight loss and coughing up blood. If you have any of those 2 symptoms, you should seek medical attention right away because those are more alarming than the other 3. The other 3, they're not specific. You could have other issues that cause those problems. Like shortness of breath, it could be related to just pneumonia or bronchitis or even heart issue. So regardless, it needs attention if any of those symptoms came up and they're more, if they cause any anxiety to you, don't just ignore it. You should go and seek attention for this. So when we have a patient with mass, let's say somebody has a shortness of breath, they went to their doctor, they did the chest x-ray, and we did find a mass in the lung. Then we have to do further workup, and that would be a CT scan, a lung specialist consultation when they do bronchoscopies. So they put a little camera and go down in the lung and look in the airway. If they find the mass, they could biopsy it. If we can't find it from the bronchoscopy, then we have to do what we call CT-guided biopsy. So under the CT scan guidance, you just lay down on the table, they numb the skin, and they go in between the ribs with a special needle, take small sample to be tested. And if we confirm, then we do PET-CT scan, which is a full body scans and a brain MRI, because lung cancer like to go to the brain, so it's part of the staging that we do brain MRI. If we diagnose patient with a lung cancer, we have to stage it. So, and based on the stage, we decide what therapy it should offer to the patient. Usually we like, if we're gonna find lung cancer, we wanna find it early, when it's stage 1 or stage 2, because that's give you your best chance of being cured. And that's also when we could do surgery, offer surgery for those patients. When it's stage 3, some of those patients become not resectable. We can't do surgery, it would be too late. So we use chemo and radiation for those patients. If the patient come late when it's stage 4, that means it has spread somewhere else beside the lungs. Then it's become not curable, and then we do systemic therapy, and that would include chemo or targeted therapy or immunotherapy. So all the research that was done to treat lung cancer or improve the outcome of lung cancer focused on 2 things. Early detection, as we said, and that's what the low-dose CT scan offered, and then improve the cure rate and the prognosis for the patient after they get diagnosed with lung cancer. Just I'll give you an example. This is a meta-analysis. Meta-analysis mean we got multiple clinical trials that share similar characteristics. We look at them together. We look at all the patient population. And then we try to ask this patient population to ask specific questions that we could answer by looking at large number of patients. So those are all the studies that we did to show that chemotherapy after surgery for early stage lung cancer improve your cure rate. And even in those studies, if you look at stage 1B, the chance that you may have relapse of the lung cancer after the surgery and chemotherapy, it's up to 45%, and that's for stage 1B. So that's very high if you compare it to other cancers. I mean, a lot of other cancers, if you're stage 1, your cure rate almost 90, 95%. So here we're still looking at 55%, 60% in lung cancer. So how did we improve outcome? Before we talk about this, maybe we should talk about this slide first, because there was another meta-analysis study that we looked at the SEERS data to see how the incidence rate of lung cancer is, what's the direction of incidence in the United States, and the prognosis. And this is a data set from 2008 to 2016. What it was noticed that there is decline or decrease in the incidence rate, about 3% a year, which is a very good news, and that's related to, as I said, less smoking. The society in general is following better healthy habits of less smoking. And there was a decline in the death related to lung cancer also in the same rate, about 3%. Until 2013, we noticed that the decline in the death rate was about 6% a year. So it's higher than the decline in the incidence rate. So there is other factors most likely that helped in improving cure rate from lung cancer. And that's probably related to here. As we said, early detection, you have a better chance to be cured from the cancer if you catch it early. Also, in 2013, that's when immunotherapy was introduced to the field of lung cancer. So immunotherapy is a new type of drugs that basically we target cancer in general, especially melanoma, skin cancer, head and neck, lung cancer. They, in a way, in an immunological disorder, because your body is equipped with a means to find cancer cells when it's formed and get rid of them. So somehow your body is not doing what it's supposed to when you get cancer. By the immune system is not recognizing those cells as harmful cells and taking them out. And that could be related to the host, to the patient himself, like if we get older or if we have a disease that make our immune system weaker, that's also will lead to have more cancers. Or it could be related to the cancer cells itself, that those cancer cells with time did find a way to evade or avoid the immune response, anti-tumor immune response. So those are drugs that could reignite your natural anti-tumor immunity, and that's would help treating those cancers. And those drugs been a great breakthrough in managing non-small cell lung cancer and even small cell lung cancer. Targeted treatments is more that we are now understanding those different type of lung cancer and what's driving those cancer cells more. So it's not like we are differentiating between small cells and non-small cells. We're looking now deep into those genes, the gene makeup of those cells, and we could tell that this cell is depending on specific gene alteration, and that's what's the driver, and then we design drugs that could target that specific pathway. And those medications would be way more successful in treating the lung cancer, for example, and less toxic because they're more targeted. They're not just poisons that kill all cells that grow fast. That would be cancer cells, but also that's why they harm normal cells too. So when you have a targeted therapy that is directed right to what's wrong with those cells, you could have much better results and less toxicity. So those are the two major breakthrough in the managing lung cancer is the immunotherapy and it's the targeting, targeted treatments.
Sorry for the interruption. We're going to take a 30-second pause to allow our interpreters online to transition. Interpreters, please transition now. Thank you.
I mean, yeah. Good. Okay. So this is actually my last slide. So we talked about the 5-year survival rate improvement. We did not notice this in the small cell. So the small cell incidence is on the decline also, about 3%, but we did not see that larger decline in death related to small cell lung cancer. That decline only was noticed in the non-small cell lung cancer. And that's understandable because small cell lung cancer management was very hard to improve for so many years until just the last 3-4 years that we did have breakthrough also in the small cell lung cancer. And thank you very much. We could. Questions?
Yes, I have a question. Doctor, can you explain to us the difference between a nodule and a mass? And how concerned should you be with the nodule?
So nodule, usually it's smaller than a mass.
Sorry, Dr. Can you just repeat the question?
Sure. So the question is how you differentiate between a nodule and a mass in the lung, right? So the nodule, usually it's smaller, mass is bigger. Nodule, we call a lesion 1 centimeter or less as a nodule. And a lot of time, as I said, it could be a scarring in the lung from previous infection or exposure to certain dust or anything. You could get a lung nodule. So not every lung nodule, it's a lung cancer. As I said, it's about 5%. If you find a nodule in the lung, it's only 5% is malignant.
Dr. Sakari, we have a question from the Zoom chat. And the question is, does family history play a part in your chances of getting lung cancer versus other cancers that may or may not?
So a lot of time, gene abnormality that inherited and it's known to cause specific cancer, increase your risk of getting other different type of cancers. For example, we all know about BRCA1 and BRCA2 in breast cancer, right? But BRCA1 and BRCA2 increase your risk of cancer, different cancers. So in men, it increases your risk of prostate cancer. So that's the same that we could see that there is specific genes that increase the risk of multiple cancers. It could be colon, could be brain, and lung would be one of them.
Thank you.
Oh, I really don't need this. Doctor, doctor, can you tell me how you get your information to the physicians that are practicing, and I use quotations around that, medicine? I had to tell my primary care physician about 3 times that I needed a CT scan. Oh, yeah, well, how long did you smoke? I said 35 years. How many times do I have to tell? How do you get your information to the doctors?
So great question. I think the doctors should have their information and they should do it. They don't have to wait for the patient to tell them what to do. That's why you're going to them.
But how does your information get to them?
Right.
So,
In primary care.
so this is, I treat the patient after the fact. This is the job of the primary care physician. They should be the one who's leading the screening. So when, I did internal medicine, so when I was in training, they told us, when you get a patient, let's say you do your well visit once a year, and in that visit, based on your age and risk factors, after you take the history, so I would ask you, you smoked for 35 years, your age, a certain age, that puts you at the high risk for lung cancer, and you have to get the low-dose CT scan. It's great to be a well-informed patient, and if your provider is not doing what he's supposed to or she's supposed to, you could remind them.
That's why getting this information into the community.
It's very crucial.
when we
It's,
go
you
to the
could,
doctor, we
you could
have-
just start this discussion and that would lead to get the right test done.
Thank you for your recommendation.
I just want to say thank you so much for your presentation, Doctor. I noticed we mentioned lung cancer being the primary reasoning for lung cancer, but what about indoor air? What about household products? What about deodorant? What about hairspray? I'm just wondering, what are the other factors other than smoking? Well, they mentioned about the environmental, of course, but I'm thinking about inside our homes, inside our apartments, the air, the chemicals that we use to clean, Lysol spray. So can you comment on those particular areas?
I mean, that's a great question. Unfortunately, I don't have answer for it. So for smoking, we know because it tested, and we know it increased the risk of lung cancer. And we know the cause effect for tobacco, smoking, and other different type of cancers. To understand the other factors, we need to do studies, and that's should be government-funded studies to do that.
We have another question on the Zoom chat. You mentioned that other smoking like hookah, marijuana are also high risk for lung cancer. Are those also recommended for screening? And I think they mean low-dose CT scan, and does insurance cover it?
So that's a great question. Also, I don't have answer for it because the study that we depend on to do the recommendation did not include it. So it was those exposure to other smokes or other habits is not in the study. So I don't know, can answer that question.
Hi, Dr. Sakar. I got a quick question. Any conclusive evidence recently on the impact of vaping and lung cancer? I'm asked that quite often in the community, and I really don't have any answer for that.
So I also don't have I'm not aware of a study that could prove this for sure, but we do know that you have those incidents of multiple respiratory failure and ARDS that led to ventilator, and it was related to vaping. And it's later on, it was found that it's specific type of vaping that they have I don't know, it's specific chemicals that was used that was related to it. But I think anything put in your lungs beside air, it's not good. So smoking anything, because all of this, when you burn anything, you have um, um, carcinogens that produced from the smoke of burning anything. So that's not unique for nicotine or tobacco. Sure.
Yes, Montu.
So the young lady behind me said that her doctor didn't seem to know what the screening guidelines were, right? And he had not made those recommendations. And then you said that these recommendations have recently changed. So what are the recommendations for screening for lung cancer?
So it's anybody who older than 50 with the smoking history of more than 10 pack per year and who have not, who is actively smoker or quit smoking in less than 15 years. So if you have quit smoking 15 years, more than 15 years ago, you don't need screening.
Doctor, can I ask also, do you have anything that you could share with us in terms of clinical trials and what trials are available, how one would go and find out if a trial is available, and what would you say in terms of someone considering participating in a clinical trial?
So, I mean, if you have a, God forbid, if anybody get diagnosed with lung cancer, definitely we encourage them to seek clinical trials because that's would help everybody by advancing the field, and it may help them. I mean, I know patients who I treated personally, and they got immunotherapy before it was FDA approved, and they're still alive because of that. So that's the value of clinical trial, to always it's offer something that probably would be the standard of care of the future. And Carmanos, in our cancer center, we have always more than 200 to 400 active clinical trials that's going on. So you could go to Carmana's website. There's apps also that it's available for anybody to download. You plug in your information and you could find out if there is a clinical trial available for you.
We have another online question for you, actually two. So is the family history smoking lung cancer connection common with things like radon and asbestos?
I think it's not related.
Okay.
But secondhand smoking, probably we did not mention it. So please, if you smoke, don't smoke around your children because you're exposing them to secondhand smoking, and that would increase the risk of lung cancer in the future.
And then the second question is, are there any efforts to develop lung cancer screening practices for individuals outside of the high-risk group?
It's a good question, but I'm not aware of any attempt to go outside the high-risk group because really the risk of lung cancer outside the high-risk group is not that high. So to develop a screening tool, the prevalence of the disease has to be at a certain point so you could have a benefit. We're talking about like at the society community at large basis. So the risk of lung cancer outside the high-risk group is not too high to invest in a screening tool.
Okay, this question is in relation to the first question we had from our friend in the front. Of the patients who end up in a nodule clinic, like you said, many of them don't have cancer, but generally speaking, how many end up needing a biopsy versus just imaging?
I don't have that percentage.
Okay.
Probably it's out there.
Okay.
but not everybody. Like usually there is a certain characteristics, and I'm not radiologist, but our colleagues at the radiology department tell us that there is special things that they look at when they find a nodule to conclude if it's need further workup or not, and also stability. So if you find something, the low dose CT scan is not the ideal test. It's just a kind of low definition if you want. It's the pictures you get, we don't use contrast. The pictures you get is not that great. The slides cut, it's larger. So when you find something suspicious, you do a diagnostic CT scan, and that would, you use contrast, you use better technique, so it would give you better picture. And that would lead, if you see anything more suspicious, you go for the biopsy. But not every nodule you see lead to biopsy. And also stability. If you're doing your, like the mammogram, you know, you have something abnormal on the mammogram, but if you do the mammogram every year and those things are stable, not changing, not growing, that means they're benign.
So I'm really concerned about early detection. And so, so you were saying that stage 3 and stage 4 aren't very good to have because they don't have good outcomes. And stage 1, unless you are having a CT scan, how do you fall into that early detection?
Really, it's incidental. Most, back in the days when I was fellow, most of the patients that we diagnosed with lung cancer was already at stage 3 and stage 4. Because when the tumor is small, you don't have symptoms. You don't lose weight, you don't cough, you're not having shortness of breath. Some people will be lucky enough that those small lesions are close to the airway and they cough up blood, and that's how you find it, small. Or they have an X-ray for any reason and you find something suspicious, and further workup, you find a lung cancer at early stage. So more than 50% was coming at late stage when it's too late. And so now with the early detection, with that CT scan, where the numbers are getting better, but is not better enough.
As the mic transitions to the back, can I ask, what's the age of the youngest patient that you've had with lung cancer?
Oh, yeah, she was 28, I think. No, it was genetic. It was not smoke.
My question is, how do the diagnosed from the primary care get the information to screen for cancer screening? And the part 2 is that I had all the symptoms, and they did say it's not cancer, but I experienced all of the symptoms up there, including the skin, mold transition and stuff, and they still have not said it's cancer, it's just abnormal. So it's still in the primary care. Should I take that one step further for myself?
I'm sorry, I can't tell you anything
I
specific
understand.
about your health, but
Generally.
if you're trusting your doctor and he did all the workup and he told you that he do not believe you have cancer.
Thank you, I understand.
Hello, doctor. I just had a question. You mentioned targeted therapies in your presentation, but I was wondering, like, what specifically is in those targeted therapies, and does it like differ between each stage?
So the targeted therapy, if I understand your question correctly, for targeted therapy, new medications that come to treat cancer in general, we always try them in the advanced stage, like stage 4, and then they make their way down to the early stage. So if we take, for example, you have a pathway called EGFR mutation in lung cancer. So we have a drug called erlotinib that was introduced in 2005, 2006, was breakthrough. People who had that mutation had the great responses. Later on, we have similar drugs, but more effective. And now those drugs, we find that we could use them after the surgery for stage 1 and stage 2, and patients will have much better outcome of less relapse. So that's usually how it's happened.
Is radiation a part of that, or is it just medication?
No, radiation is not part of it. Radiation is like chemo. It's an X-ray that also targets cells, good and bad, but you focus that radiation, those rays, on the tumor. So they're not targeted therapy.
Okay, thank you.
Okay.
We have room for about 2 more questions.
Okay, and I actually have two Zoom chat questions. One, which you mentioned hookah before, but definitely want to reiterate your answer. So is there common belief in the area that smoking hookah is safer than cigarette smoking? Is that true? And if not, do you have a good source of educational information for the community about hookah?
So I don't believe it's safer. Probably it's more dangerous. I saw some data online, and I don't know if it's true or not, but one hookah is equivalent for 1 pack of cigarettes.
Wow.
So that could be the answer for that question.
Okay, but what about the educational information? Is it out there just to educate people on what you just said?
I don't know. I mean,
No.
probably it should be.
Yeah, it should be. So then the other question is, are there any adverse events?
Unfortunately, it's increasing.
Oh,
So
yeah.
if you go, especially in the Middle East, I go visit back home, and it's really bad.
Yeah. Are there any adverse events associated with lung cancer screening? So like the low-dose CT or the biopsy? Are there any adverse effects?
Oh, definitely. Any test you do has adverse effects. So for any screening test, the first things you need to think about is doing unneeded workup, unneeded tests, and all the risks that come with it. So as I said, you may get to a nodule that you feel it need to be biopsied, and it's benign, it's not cancer, and the biopsy has all the risk. You could have a punctured lung, you could cause pneumothorax. It's not high, but it's risk. It's a procedure. You could have bleeding, you could have infection. So all of this, it's kind of the adverse events from doing tests. That's why when we recommend screening for the community, you have really to be sure that it's going to help. That's why all those studies look at survivorship. So we find that people at certain age, for example, women at certain age, if they do mammogram once a year, they live longer than people who do not do mammogram. And the same thing for the low-dose CT scan for that specific group. That's why I told you we would not recommend screening for somebody who is not from the high group, high-risk group.
So doctor, what are the adverse effects of the low dose CT, would you say?
So it's the radiation exposure. And then if you get unneeded test after you do that.
Okay. So it's once a year that's recommended?
Once a year.
Doctor, let's thanks the doctor. He's done an incredible job. Thank you. Thank you so much, doctor. Really appreciate it. Thank you. Awesome. Now it's time to take a moment and reflect on what we've learned. We just have a few quick questions to help us think about the key takeaway from today's session. For those of you joining us in person, please take a moment now to complete the highlighter yellow colored sheet of paper tape labeled post-knowledge questions. One of our COE team members will be coming around to collect them. So if you will take a moment to do that. And for our participants joining via Zoom, a poll will be launching on your screen in just a moment with the same 3 questions. Please take a minute to answer them using your device. Oh, they want me to read the questions. Thank you. Question number 1. Question number 1 is cancer is the most common cause of cancer-related deaths? Lung cancer is the most common cause of cancer-related deaths. You can reduce the risk, this is question number 2, of lung cancer by not smoking. Question number 3, which of the following is considered one of the most important advances in lung cancer management in the last 10 years? So take a moment. I'm sorry. Take a moment to look at those. I just want to finish and thank all of you for your participation, okay? So before we go through the answers, I want to remind everyone to complete the evaluation included in the packet that was found on your chair. So look at the evaluation form, complete that, and if you will, now we'll go through the answers, okay? And I'm going to elicit a little bit of help, okay? Question number 1, raise your hand if you think it's true. Oh, you're not looking at the questions. Lung cancer is the most common cause of cancer-related deaths. True, very good. You pass, okay. We're not finished. You can reduce your risk of lung cancer by not smoking. Wow, I didn't even get to, okay. Great, you've been listening, and we've all learned. Number 3, which of the following is considered one of the most important advances in lung cancer management in the last 10 years? And you know, I wish the doctor had really spoken more about immunotherapy. That is incredible, because think about it. It's taking the drugs and awakening our own immune system to do the work. So it's fewer drugs that are being used and that are harmful in our bodies. So you did great. You know, everybody got an A. There you go. Great job, doctor. Great.
Thank you, everyone. So just a few quick things before we close out. Thank you so much, Dr. Zakari, for a wonderful presentation. Thank you to our moderators, Jim, Katrina, and Patrick. And another thank you to our community partners and the Detroit Public Library. Another round of applause. And so we will have the we will have the recording up, and we will email everyone as soon as we have those up. For anyone who wants to watch the recording, and on the behalf of the Community Outreach and Engagement Office, we would like to thank you all for being with us tonight. And be sure to fill out your evaluations. Otherwise, have a good rest of your evening.
Thank you.
Nice job.
Did a great job. You too. Phenomenal job.
You're great at this.
You're great at this. Brought it on.
Yes, he did. Thank you.
And thank you to our participants online.